Great. Welcome back to everyone. Now we are going to transition. Our last comment from the last session was around the other factors in community and in the policy environment and the policy framework. So that's what we're going to turn our attention to next. And this will be an interesting session flow. We're going to present some of the work of the planning committee and then have a reactor panel and then open it up for conversation. So we have a good long time to really dig into those factors that enable the care models and some of the work that we were just talking about, but even enable the health for high needs populations more broadly. So we'll start with my colleague David Blumenthal, who is the president of the Commonwealth Fund, and then we'll hear from Jerry Anderson, who's the director of the Center for Hospital Finance and Management at Johns Hopkins School of Public Health and a member of the Planning Committee. And then we'll hear from Catherine Hayes, who's the director of health policy at the Bipartisan Policy Center and also a member of the Planning Committee. So I welcome David Blumenthal.
Thank you, Peter. Can you hear me? Sometimes I'm height challenged, so sometimes these things don't capture my voice. Imagine that we had solved the problem. We had the perfect match between patient characteristics and models of care. Would that guarantee our success? And I think the answer is clearly no. The best models exist in a context. That context can make it easy or hard to do the right thing. The perplexing problem of scaling, which we all beat our heads against. I can't count the number of seminar rooms I've sat in where the issue under discussion is how to disseminate effective models. I know there's some of you in the room who care deeply about that. So the context has a lot to do with that question of scaling. Context can make it easy or hard to do the effective and the right thing. So context consists of a lot of factors: culture, nature of the workforce, how we pay for things, how we regulate things, and a lot of those factors are influenced by policy. Policy is an elusive concept. It happens in many ways at many levels of government and even in the private sector. We've had it emerge spontaneously today in a number of contexts. The S3130 as a policy promoter or inhibitor of a apparently successful model of intervening for high-need patients. And implicitly in the background is the changing payment context for Medicare and Medicaid that have made this topic that we're discussing today highly relevant. And as Arnie Milstein talked about the history and how often we've wrestled with this problem, he implicitly raised the question of why it is that we're coming back to it. And I think we're coming back to it because the policy context has changed. The concept of value-based payment has made this patient population, however the committee and Melinda and Arnie and others are going to define it for us, this patient population newly relevant and its needs newly urgent. So it's in that context that this panel is so relevant, and I'm delighted to welcome it. I'm delighted also on behalf of the Commonwealth Fund to thank the National Academy of Medicine for making this meeting possible, to Peter Long for chairing the working group and the process, to my other colleague foundations, Peterson and SCAN and Hartford and the Robert Johnson Foundation for joining us at the Commonwealth Fund in this pursuit of this the solution, which hopefully the context will enable to spread. So with that, I'll welcome Jerry Anderson to the podium.